Is this on? Hey, good morning, guys. So I'm up here to introduce Katie Larson-Nath. Katie Larson-Nath is a pediatric gastroenterologist here at the university. She did her medical school and her residency here, but got away and did her GI training at Milwaukee, bringing us new ideas and new thoughts. Her area of expertise is short bowel in children and nutrition in children. And I think she's going to give you a very interesting talk, something that you'll be able to use over the Thanksgiving holidays and anytime you're with your families and they come up with wacky diets that they want to try. Okay?
All right, thank you, Sarah Jane. So today we're going to talk about diet trends, alternative diets, fad diets. There's lots of different words from there, things that I think everyone runs into in their daily practice. So the obligatory, I have no disclosures. So the objectives for today's presentation are to recognize the evidence behind current popular diets and dietary trends. We'll go over the FODMAP diet, fructose elimination, the gluten-free diet, and alternative milks, and to identify ways that specialized diets may impact overall nutrition. So why do people want to undertake a different diet, a specialized diet? It may be that they feel like it's going to be healthier, that it's less processed or more natural for their overall well-being, to treat a specific disease. One of the major ones that we see within the pediatric gastroenterology world is functional gastrointestinal disorders. It may be to lose weight. They may feel it's better for the environment. And for many patients is that it gives them an active involvement in improving their own health. So many diets are used to treat functional gastrointestinal disorders. Functional gastrointestinal disorders actually account for more than 50% of visits to the pediatric gastroenterologist's office. And up to 20% of children at some point in their life, during their school year ages, will meet the criteria for irritable bowel syndrome, one of the more common functional gastrointestinal disorders. Functional gastrointestinal disorders are recurrent gastrointestinal symptoms that are not due to a structural or biochemical abnormality. This means that we don't have a blood test or a procedure or another way of diagnosing these. They tend to be diagnoses of exclusion and fitting a set of criteria. There's a wide range of functional gastrointestinal disorders, everything from irritable bowel syndrome, functional dyspepsia, some forms of constipation, to cyclical vomiting syndrome or abdominal migraine. So we'll first start talking about the FODMAP diet. FODMAP diet, FODMAP stands for fermentable, which means production of gas in the intestine, oligosaccharides, which are fructans and galactans, disaccharides, lactase, sucrose in large amounts, and maltose, monosaccharides, fructose, and polyols, which are sugar alcohols. Up to 40 grams a day of undigested carbohydrates and FODMAPs will enter the colon. How might these substances impact abdominal symptoms? So sugars enter the gastrointestinal tract. Some are digested, as you can see here with lactase. Lactose is converted to glucose and galactose. Fructose can be absorbed via a couple pathways, but some of these sugars are not digested. And then they travel down into the colon. Once in the colon, they bring water with them, and the bacteria start fermentation because they're using these sugars as energy, producing gas such as hydrogen and methane. These go further into the colon, causing luminal distension, and the thought is acting actually on increased visceral hypersensitivity. Some studies have actually shown that the degree of distension is not proportional to the degree of pain, which means it's thought that actually it's more internal patient response. So someone may have less distension but have more pain, and so it's the thought that the visceral response and how responsive the nerves are actually the cause and not the amount of pain itself. Different sugars also produce different symptoms. For instance, fructose produces more water and less distension compared to fructans. Other mechanisms that have been proposed include leading to increased GI motility, the changes in the intestinal microbiota, and reduction in production of short-chain fatty acids. None of these have been consistently proven to cause gastrointestinal symptoms, but some studies indicate that they may be contributing factors. So this is a list of common foods that are high in FODMAPs. What you can see is that this is very extensive. Things with high in lactose, such as cow's milk, vegetables and fruits with sweeteners and high in fructose, such as asparagus, tomatoes, apples, and mangoes. And I think some of the most difficult ones are going to be the ones high in fructans or galactans, like onions, garlic, and soy. Taking those out of the diet can be very difficult for people if you start thinking about what's really included in foods. Fruits and grains with high levels of fructans are things like apples, watermelon, and wheat. And then foods with high in polyols include broccoli, prunes, pears, and sweeteners such as sorbitol and mannitol. There is limited evidence on the effectiveness of the FODMAP diet in children, partially due to the difficulty of performing well-controlled dietary studies. If you think about it, it's very hard to blind someone to a diet that they are getting. And so there is a lot of risk for placebo and nocebo effects. Chimpuzzi and his colleagues have actually performed 2 studies, though, looking at FODMAPs in kids in a relatively controlled setting. In their first study in 2014, they looked at 12 children who had irritable bowel syndrome, although only 7 of these children were able to complete the study due to the difficulty of the dietary controls. What they found is that the pain episodes and pain severity were significantly better on the FODMAP diet. So the children who were on the FODMAP diet had significantly fewer and less intense pain episodes. But there was no difference in the number of pain episodes that interfered with daily activity. So while it was significantly better, it did not impact their daily life. They also looked at the number of bowel movements, and there was not a significant difference in the number of bowel movements between those who responded and those who didn't. In addition, they were looking at the microbiome and found that there were a decreased number of Bacteroides in the microbiome of the children who responded to the diet. This was a non-blinded study. So in their second study, they actually did a double-blind crossover trial. 33 children were able to complete the study. What they found here is that 8 responded only when they were on the low FODMAP diet. 15 had no change in symptoms for either of the diets, and 10 had what they called more of a placebo effect. They either improved on both diets or on the typical American childhood diet. With this controlled diet, what they actually did was had provided meals for the children and that were designed to be equivalent. And so if a child were to, in the FODMAP section, they would get a lactose-free milk, while the child on the typical American diet would get a lactose-containing milk. The number of pain episodes per day was significantly less at 1.1 on the FODMAP diet compared to 1.7 on the typical American diet. And the median pain severity on the FODMAP diet was 1 compared to 2.5 on the typical diet. So that's the diet they used as control, so it would be not the FODMAP reduced diet. Like a normal diet, yep, normal child diet. And so what they did is they had a similar menu, and then they took FODMAPs out. So for instance, a child who had, if they were giving milk, the patients on the FODMAP diet would have lactose-free milk, while the patients on the typical diet would have lactose-containing milk. And so they would make a bread that was FODMAP agreeable and give that when the child was on the FODMAP diet and not on lactose diet. Again, it gets to the point that it's hard to control because these foods are going to taste differently. What should be noted, though, is that even on both sides, they improved from baseline regardless of what diet they were on. So the pain scores on the FODMAP diet were 1, and on the typical diet were 2.5. They looked at hydrogen and methane production, which again was not different between the groups. And contrary to the previous study, those who responded actually had increased Bacteroides and other saccharolytic bacteria in their microbiome. One reason that we look at Bacteroides is that it uses sugar as its energy, and so it was thought that that might produce more symptoms if the gas production goes up when you are on a typical diet, and you would expect that gas production would go down when they're having less exposure to these sugars that the bacteria can digest. So in general, there's limited evidence in pediatrics, but some patients will respond. All studies have been short-term, and again, likely these are going to be beneficial. FODMAP diet will be beneficial in a small group of patients. There are likely host factors that are likely the reason for efficacy. We still do not know what these are. Could it be the microbiome? There's conflicting results based on the small studies that we have right now. Is it the visceral hypersensitivity and how sensitive an individual's nerves are? Is it how an individual is going to be responding to metabolites and how that differs? And there's a lot more research that needs to be done to help us better understand which children are going to respond to this diet, because it's not easy to take this many foods out of, especially a child's diet. Attention is needed again for all these diets. It's going to be a recurring theme to make sure that there's nutritional adequacy, because anytime that you're taking foods out, you are going to be at risk for nutritional deficiencies. And when we're doing the FODMAP diet, we always recommend that foods are slowly reintroduced after 8 to 12 weeks to find when symptoms start to improve. Now we'll talk some about fructose intolerance. Fructose is one of the FODMAPs, and has been recently, a lot of people we are seeing, at least in our clinic, a lot of patients coming in who have been diagnosed with fructose intolerance elsewhere. And I think there's a lot of controversy on whether this actually exists. So a little bit about fructose intolerance is that fructose is a monosaccharide and is used as a tasteless sweetener. There are many natural sources of fructose, such as honey, dates, raisins, molasses, and figs, grapes, apples, and persimmons. Consumption of fructose has actually increased by 25% between 1970 and 2000, mostly due to the addition as this tasteless sweetener into foods. Fructose on its own is poorly absorbed by the GI tract, and we'll talk a little bit about that. And it's also important to know that this is not at all related to hereditary fructose intolerance, which is a rare disease due to the lack of aldolase B that presents in infancy. So again, these are very different disorders, and if your patients are starting to use Google, there can be a lot of scariness and confusion for them. If we look here, would be a fructose diet that was used in one study. The foods that are allowed are listed here on the left, and the foods to avoid are listed here on the right. Again, like for the FODMAP diet, is quite extensive. It includes things such as apples, cherries, coconut, dried fruits, pears, watermelon, ketchup, a favorite among many children, syrup, and honey. Sweeteners also, such as Splenda, sucralose, and lactulose, and sorbitol, should not be used. So how is fructose absorbed? So as I was saying before, fructose is a monosaccharide, and it's also part of the disaccharide sucrose when it's paired with glucose. On this chart, the darker pathways are the proven routes of absorption for fructose, and the light gray pathways are proposed routes. What we know is that fructose first is dependent on the GLUT5 transporter. This is located on the brush border in the intestine, and crosses the brush border via concentration gradient and facilitated diffusion. This means that the GLUT5 can easily be saturated, and we also know that there's actually a relatively low concentration of GLUT5 within the human intestines, making it very difficult for fructose to be absorbed. Once it crosses the apical barrier or the brush border barrier, it comes to the GLUT2 transporter, which is on the basolateral membrane. And this is a co-transporter between fructose and either glucose or galactose. Some people will advocate that you can absorb fructose better if you take it in with glucose or galactose, although due to this co-transporter, although those other studies do not correlate with that. So again, the big thing I think is that this GLUT5 is going to be the rate limiting step for fructose absorption. So once this gets saturated, you're not going to be absorbing fructose. So this study looked at children to see if the amount of fructose ingested and caused symptoms, and what happened when children who had positive breath test results, so looking for some of those gases after fructose ingestion, took fructose out of their diet. They looked at 32 children between the ages of 7 and 17 with irritable bowel syndrome, functional dyspepsia, or functional abdominal pain. And all of these children underwent a breath test. They underwent the breath test from one of 3 different doses of fructose. So the first group, the high fructose group, had 45 grams of fructose. This is actually equivalent to about 5.5 tablespoons of honey. So it's quite a bit. And I think easily, when we think about the pathophysiology of how fructose is absorbed, is easily going to saturate your receptors. 13 patients were in this group, and 8 were shown to have malabsorption, but all of the patients in that group actually had symptoms to some extent. And you can see here in this chart on the left, these are represented by the black line. Many had multiple symptoms associated with the fructose absorption in this test. So even though they were all having symptoms, they all did not respond, or they all did not have a positive fructose breath test. Very much indicating that this is probably not going to be a reliable test. The middle group received 15 grams of fructose, and only 3% of these children had symptoms. And then the last group received 1 gram of fructose, and this was used as the control group. So the chart on your right, when someone was had an abnormal breath test, they then were put on a low fructose diet. And what was found is that symptoms did improve, indicated by these stars on the low fructose diet. One major flaw with this study is that it was only the children who had positive breath tests that they put on the low fructose diet, and not all children, including all children who had symptoms. So it's unclear if you can't make a correlation between the abnormal fructose breath test is the indicator for improvement in symptoms. Escobar and colleagues tried to do a similar study with a larger group of patients. They used a smaller dose of fructose and doing more of a weight for their breath test, doing more of a weight-based dosing at 1 gram per kilogram, up to 25 grams. Out of 222 patients that they enrolled, 121, or about 56%, had positive breath tests. And then these patients with a positive breath test, so similar methodology to the group before, were placed on a fructose elimination diet, and 76.9, or about 77%, had improvement symptoms with these dietary changes. They also followed the children who did not have who had symptoms with the fructose breath test, but did not have a positive test, I should say. And 55 out of those children, or about 54% of those children, responded without any dietary changes. Again, showing that there is little correlation between the breath test and the dietary response to fructose elimination. Probably the best test best study that's been done, though, has been this study here, where they actually blinded the providers and the families to the results of a fructose breath test. So here they looked at 103 patients with abdominal pain for more than 3 months. All patients underwent a breath test, again with that 1 gram per kilogram dose of fructose, up to 25 grams. But no patients or providers knew what the results were. They then split these patients into 2 groups. The group here on your left will be the patients who were put onto a low fructose diet. And you can see on the x-axis, there's the negative group. So these would be the patients who had a negative breath test, did not show fructose malabsorption based on the breath test, and then the positive group, which did not show which they did have changes on their breath test. This group on the right, they did not make any dietary changes. So patients knew what diet they were on, but they did not know the result of their test, trying to take out some of that possible placebo effect or nocebo effect. When on the y-axis is going to be changes in the pain intensity. So what we can see is that all children, regardless of their breath test results, had a significant improvement in their abdominal pain when they're on the low fructose diet. Could this be partially because they knew they were changing their diet? Yes. But there was no difference between the groups based on the test results. And if we look here, those on the regular diet, they did not have a significant change. But again, there was no difference in results based on the breath test. So what the study shows is that pain improved in these children regardless of their fructose breath test results when they're put on a low fructose diet. Again, possibly due to the fact that GLUT5 is very saturable, and everyone at some point is going to malabsorb fructose. What hints at this a little bit more is that there were 33 children who reported symptoms in relationship to their breath test. And all of them had significant improvement in symptoms at 2 weeks, regardless of which diet they were put on. So for fructose malabsorption, when enough fructose is given, it will be malabsorbed. Fructose breath tests, I feel, are useless. There is no correlation between breath test results and pain improvement in well-designed studies, although we have not had the ideal double-blind crossover control, partially because it's just very difficult to do. And like many, you're going to see a recurring theme here. It's unlikely that fructose malabsorption alone is the cause of pain symptoms in children. There's a high chance for placebo effect. And we need to think about other oligosaccharides and polyols that may come out of the diet when fructose is removed. So now we'll talk about gluten sensitivity. Wheat has become a big thing and throughout society. There's many books talking about the evils of wheat. It's kind of become the boogeyman. So there are many wheat-related disorders. The ones that we have ways of diagnosing and good evidence include celiac disease, which is an autoimmune disorder related to wheat ingestion, IgE-mediated wheat allergy, or non-celiac gluten sensitivity. Non-celiac gluten sensitivity is intestinal and extraintestinal symptoms correlated with gluten ingestion that is not secondary to celiac disease or wheat allergy. There's a wide range of symptoms associated with non-celiac gluten sensitivity, including bloating, diarrhea, abdominal pain, dyspepsia, fatigue, headaches, numbness, brain fog, joint pain, depression, and fibromyalgia. So why do we care? Well, our patients are avoiding gluten, even in the setting of not having celiac disease. And spending on gluten-free foods was $15 million in 2016. This is double what it was 10 years prior. So the percent of people avoiding gluten without celiac disease based on NHANES data is shown here. What we can see is that for all ages, in 2009 to 2010, 0.52% of patients were avoiding gluten. This increased, again, on average in all ages to 1.69%. So almost 2 people of every 100 you meet are going to be, without celiac disease, are going to be avoiding gluten in their diet. This is not limited, though, to just adults. What you can see here is that in children in 2009 to 2010, 0.15% were avoiding gluten. And you can see a dramatic rise up to about 0.83% in between 2013 and 2014. So it's very important that we pay attention to these patients and what avoiding gluten can do. So what's the diagnostic criteria? Well, like many things, there are no consistent or reliable laboratory markers. These children must rule out celiac disease and wheat allergy first. And once someone is already on a gluten-free diet, you cannot diagnose celiac disease, which is very important, I think, when talking about risks with families of starting empiric diet elimination. The gold standard diagnosis in the research setting is definitely not applicable into the practical clinical world. What you need is at least 6 weeks of gluten-containing diet, and then going into a 4 weeks of gluten-free diet where you should see symptom improvement. After that, patients should have either gluten or placebo. I would say in the clinic, you would ideally just give them some gluten back to see if symptoms return. And then 1 week of a gluten-free diet washout period for a study, and then crossing over to whatever the other group is. Again, not very practical. There are many proposed pathophysiological mechanisms for non-celiac gluten sensitivity, including increased pro-inflammatory cytokine production, There's some suggestion in studies about an adaptive immune response, as some studies have shown increased serological titers with things like anti-Gluten antibodies, although these are definitely not consistently improved, as some consistently proved, as some studies show the reverse, that there is no difference. Other studies have looked at the actual intestinal tissue and have shown increased expression of toll-like receptors, indicating possibly an innate immune response. It could be that it's not actually a response to removing the gluten itself, but other proteins that go along with gluten or other unknown factors. So does non-celiac gluten sensitivity exist in children? A recent paper has tried to determine this. This is an Italian multi-center study. It's actually a double-blinded prospective crossover study. The goals of the study were to first identify any correlation of symptoms of irritable bowel syndrome and gluten ingestion, and then with the children who may have a correlation between symptoms and gluten ingestion, enroll them in a double-blind placebo crossover study. So they started with actually 1,100 children who were screened for the study, but only 36 were found to be eligible based on criteria of a symptom associated with gluten. So these are 1,100 patients who came in with irritable bowel syndrome, but after thought to be maybe related to gluten, but after more detailed evaluation of symptoms were found only 36 actually had relatively reliable clinical response. So these 36 children were then put on a gluten-containing diet for 2 weeks. Not a hard thing to do in Italy with all the pasta. And symptoms were then assessed using a visual analog scale for pain. 5 of the children, when they were put back onto the gluten-containing diet, had no symptoms on this gluten-containing diet, so were removed from the study. The 31 children then went into the second part, into the open gluten-free diet for 2 weeks. 3 of these children did not improve once gluten was taken out of their diet again, so they were removed for the study. After that, the children were randomized into 2 arms and took a sachet daily of either placebo or gluten for 2 weeks, which has been is a relative standard duration to see symptoms based on adults and some pediatric studies as well. Each of these sachets of gluten had 10 grams of gluten in them, and parents would spread them over the food throughout the day, so they weren't getting the gluten all at once. They then went on a washout period for 1 week where they were back onto a gluten-free diet, and then they crossed over and had the sachets again. So they used 3 scales to assess symptom response: the visual analog scale, the IBS severity scale, and the state trait anxiety index for children. All 3 scales showed similar results. When looking across all time frames in the study, there was a significant difference in scores, with higher scores during the open gluten period and lower scores during all the rest of the study. What is important to note, and is seen in this box, is that the difference between the scores in the 2 blinded portions arms, or the blinded arms of the study for assessment, were not significantly different for any of the, for either of the groups. That means that when patients were blinded to gluten ingestion as a group, there was no difference in symptoms. So as a group, they did not respond, but we treat individuals and not groups of people, and I think that's a very important thing to know. When looking at individual patients, it's clear that a small proportion of patients do show a response, and this has been shown in adult studies as well. So in the graph on the left here, each cross or dot represents a patient. The x-axis is their visual analog scale score, and the y-axis, the visual while on placebo, or on gluten, and the y-axis is their visual analog scale while they are on placebo. So patients who fall closer to this diagonal line are going to be ones that had similar scores on both groups. These 4 patients here in this quadrant were felt to have a significant improvement in pain, much higher when they were on the gluten compared to when they were on the placebo, and are likely the patients with true non-celiac gluten sensitivity based on this blinded study. This is only 4 children, or 14% of the patients. So what this study shows is that while a lot of children initially were thought to have non-celiac gluten sensitivity, only a very small portion of children had confirmatory response in the study. And based on the number of referrals they estimated that the prevalence was about 0.36 to 0.96% of children who were referred for abdominal pain will have true non-celiac gluten sensitivity. So we don't have blood markers. People, this is what I've been telling you, people have looked. This study here looked at children, and they took 3 groups, a control group with no symptoms, those who were thought to have gluten sensitivity, and those with celiac disease. What they found was that the anti-gliadin antibody IgG was positive, was significantly higher in those with gluten sensitivity compared to controls, but the number of positive results was not significantly different between those groups. They also found that the TTG-IgA was significantly higher in those with gluten sensitivity, again, clinically based, not based on a blinded study. But none of these levels would flag as being positive on a test. So we do not have a good serological marker or reliable serological marker, especially when we start looking at some of the more studies in the adult population have shown that this does not correlate, and larger studies would be needed to both find a cutoff value and, more importantly, to confirm that any serological testing is related to gluten sensitivity. Anytime you remove foods from your diet, you put a patient at nutritional risk. Patients with, a lot of our data does come from celiac disease and not non-gluten sensitivity, but it has been shown in celiac that patients on the gluten-free diet have increased caloric intake, carbohydrate intake, fat intake, and lipid intake, and are at risk for these micronutrient deficiencies, including zinc, magnesium, iron, vitamins B, vitamin D, calcium, folate, and fiber. Most of the information, again, like I said, most information is coming from our celiac disease population. This Italian study looked at how the diet for patients with celiac disease differed from the pediatric patients without celiac disease. And what they found is that these certainly have more calories, higher percent of calories from carbohydrates. These, again, are the celiac patients. A lower percent of calories from fat, and overall higher glycemic index of intake. These differences can clearly be explained by simply looking at the nutritional content of available gluten-free products. This chart compares the mean nutritional values of various breads and pasta production between gluten-free and non-gluten-free products. So when looking at breads, gluten-free breads had significantly higher fat, actually almost double per 100 gram of bread. They also had significantly less protein and iron. Gluten-free pastas had significantly more carbohydrates and significantly less fiber, sugar, protein, iron, and folate. What about toxicities? So again, this is using, we'll look more at the bottom half of this chart. Using NHANES data, they looked at patients who did not have celiac disease and but were on a gluten-free diet. And what they found compared to controls is that controls not on a gluten-free diet, that patients on a gluten-free diet had significantly higher blood mercury and blood level, higher urinary arsenic levels. So this is not benign. And they did control for things such as fish intake and rice intake, which are known contaminants. Cost is another big issue. So this Canadian study looked at the cost difference between different gluten-free foods and found that on average, per 100 gram of food, gluten-free foods cost $1.99, whereas the standard foods, non-gluten-free, were $1.23. This is a 163% difference between, the gluten-free foods are 163% more expensive for these families. So it's not benign in a cost perspective either. So non-celiac gluten sensitivity exists, but is not very common. The pathophysiology, like everything I've been talking about today, is not well understood, and it might not even be the gluten protein itself leading to improvement in symptoms in patients. We do not have biomarkers to reliably diagnose this, and celiac disease needs to be ruled out prior to empirical elimination of gluten at any time. There are monetary and nutritional costs associated with gluten elimination, and gluten elimination should only be undertaken with assistance of a registered dietitian due to the risk of nutritional deficiencies. Lastly, we'll talk about alternative milks, and I have a hard time even having milks on here because they are nowhere close to milk. So cow's milk consumption has decreased dramatically over the last 35 to 40 years. What we can see here is that when data was first obtained, on average, U.S. citizens were taking 250 pounds of milk a year. This has decreased about 150 pounds in 2015. Over the same time, cheese and yogurt consumption has increased, What's interesting is that frozen dairy products, their consumption peaked in 1995 and have been steadily decreasing since then. So I guess less ice cream. So looking at NHANES data, again, we can see that all age groups have had significant decrease in the percent of people consuming cow's milk. The biggest decrease, though, has been in the 12 to 19 year age range, where about 80% of patients in this range were consuming cow's milk in 1970, and between 2005 and 2006, only half were consuming cow's milk. There recently has been some concern in the media based on one study that do these alternative milks, again quotes over milks, cause some deleterious effects in regards to linear growth. So this was actually a cross-sectional study of 4,100 Canadian children. In this study, the researchers looked at the number of cups of cow's milk and non-cow's milk and cups of non-cow's milk children drank each day and how that affected their height Z-score. Each cup of cow's milk consumed equated to a decrease in height Z-score of minus 0.1, which may sound little, but for a 3-year-old, that's equivalent to minus 0.4 centimeters. So a child who took in, a 3-year-old who took in 3 cups of non-cow's milk would be 1.2 centimeters shorter, which is about the difference between the major percentile lines for that age on the growth chart. One postulation that the researchers had for the difference is the presence of animal-derived IGF-1 and other proteins, which is known to be a growth factor in cow's milk that is not present in these other alternative beverages. One major issue with the study is that since it is a cross-sectional study, we do not know if these differences persist, worsen, or lessen with time. And so definitely more data is needed. So while the jury is out on if kids who drink alternative beverages are shorter than their peers, the nutritional content of alternative milks vary greatly. And in addition, there is no standard for fortification like there is for milk. So vitamins A and vitamin D do not need to be included in these alternative beverage products. One of the big areas that we see, and was alluded to maybe in that previous study, is the protein content. And so if we look here, cow's milk, soy milk, and then these pea-based milks have a good amount of protein. We start looking at rice, almond, and coconut milk. They have almost no protein, and this is one of the big components of milk that is important for children. Another big difference is the amount of sugar. There's a wide range in most of these types of milks, but you can see here rice milk especially has a lot of sugar, and this is needed for palatability for children. In addition, we can see here that there is not a standard fortification of these milks, and so parents have to be very astute to looking if they are getting milks with the vitamins and minerals that patients need. So these should not be called milk. They are not nutritionally equal. They do not have similar protein. They're not required to be fortified, and often will have higher sugar and fat. They are needed. These alternative drinks are needed for people with milk allergies, especially IgE-mediated allergies. And I would advocate that lactose-free cow's milk should be encouraged for those with lactose intolerance and not these other alternative beverages. I also just want to make a quick comment on raw milk. Raw milk is dangerous. No one should drink it. The risks of outbreaks from raw milk is 150 times higher than it is from pasteurized milk. And the number of outbreaks, infectious outbreaks linked to raw milk is 1.7 times higher in 2010 compared to 2012. And 81% of outbreaks have been in states that allow the sale of raw milk, whether that is commercially or direct sales on farms. So conclusions, this is only the tip of the iceberg. There are many other diets out there. Most of them do not have much research. Things such as the paleo diet, anti-inflammatory diet, and ketogenic diet. This is not the ketogenic diet for seizures, but the ketogenic diet that some people are doing to help with their overall health. So diet is something that gives families agency and control, which is why a lot of our families and patients would see this as a way that they want to actively improve their health. But eliminations are difficult. Child going to school and eliminating from their diet is not easy. If you think about patients with celiac disease and eosinophilic esophagitis who, for reasons that we can, that have to eliminate foods, they have a hard time, and socially it can be difficult as well. These eliminations can be expensive, and the effectiveness of the diets is limited to very small groups, and unfortunately, we do not have good, reliable testing for really any of these diets to see who is going to respond to them. There's risks of nutritional deficiencies and toxicities, and long-term outcomes of these diets are not known for children. So as providers, we must counsel our families about the evidence surrounding these diets, and no diet should be started without assistance of a registered dietitian. And that's what I have. Thank you. Yes, Joe.
Early on in your talk, you mentioned that 20% of children meet the criteria for irritable bowel disease at some point during childhood. I'm guessing somewhere around 2% of those children are going to have a diagnosis based on what you presented here. So what happens to that other 18% group?
So, if they see us, it depends on symptoms and family. A lot of them, in general, these kids get better. It's going to be different for different periods of time for children, and it's working on a lot of the reassurance, making sure that we aren't missing something that needs to be treated differently, making sure that there isn't inflammatory bowel disease, that there's not celiac disease and other things that may be causing these kind of very vague and diffuse symptoms at times. But out of that 20% of children, 90 to 95% will get better kind of just on their own without interventions. Not reliably, no. Yes. Yeah.
So, say you have a patient coming to you who has been, like you mentioned, has a diagnosis of, let's say, fructose insensitivity from an outside clinician. We know from other studies showing that if you present evidence to people that contradicts what they have previously held belief, that they actually more get grounded in what they already know. So we have the evidence here, knowing that if you show them this evidence, they might actually get firmer into their belief that, no, I do have, let's say, fructose intolerance. How would you best present this information, what you're talking about, to your patient without having them think that you're being quote-unquote insensitive, combative, like you don't believe me, yada, yada, yada?
I think that's always the difficult part of things. And you want to provide that trust and relationship with your patients. I present kind of the evidence, and then here it's easy to say is that a lot of people malabsorb fructose. You can try taking it out of your diet, but that doesn't mean you're necessarily going to respond. And then if you don't respond, that we are here to work as a team, and we can come up with other ways to help make your symptoms feel better and look at other methods for helping improve their overall health. Does that answer your question? So basically, saying that everyone is going to do this, is going to malabsorb fructose. So taking some out of your diet, is reasonable, but if it doesn't work, that we are there to help figure out why or how we can best make you feel better.
The study that looked at the decreased linear growth rates for the children that were given alternative milks, did they look at overall protein intake, or, it's hard to control a general diet. So I'm curious if there's more to that.
Yes, they did not specifically look at overall protein intake. This was again, cross-sectional study based on a survey of parents in Canada, which I think is another big portion of this. Were there more vegetarians in the group using the alternative drinks, which I think you could definitely postulate would be the case. And so I think that's why the study, while it's there and kind of actually has these very scary headlines, needs further replication and evaluation, looking at more longitudinal basis of these children. What I didn't put in there is that they actually did look at how much, for kids who drink both these alternative beverages and cow's milk, they actually saw that there was a little bit improvement in the kids who had some milk, and so Z-scores were a little bit better on kids. The kids who drank both cow's milk and these alternative beverages had kind of a middle ground of Z-scores compared to those who are simply cow's milk and exclusively the alternative beverages.
So in the early days of ADHD, we used to do placebo trials with the stimulant medications.
Yes.
I'm just wondering if there are any models out there, or if you're familiar or think it would be practical to offer families as an option a placebo versus standardized dosage of whatever dietary ingredient they're curious about, as a way of using some objective data. Again, I think sort of illustrating the earlier point about creating some oppositionality or defensiveness on the part of the families, having to navigate that really gently, but opportunity given that they're introducing additional expense, concern for nutritional deficiency. Would you like to know more about whether or not introducing this dietary ingredient in a blinded manner seems to make a difference? We could investigate that together. I'm wondering if there are any models for that.
There aren't outside of these studies, and I think that would be very interesting and an interesting way to go about things. I think it's very hard to control diet, and most of these kids are not having every meal totally made for their children, which again makes it harder. Especially, and then you get into the fact that that you're eliminating gluten or not. So I think it would be interesting way. Could you give those like sachets of gluten and just have people on gluten-free diet? I think that would be great. I don't know how practical it is, but I think that would be wonderful.
Yeah, that was a wonderful talk. I just wanted to make a comment on the raw milk.
Yeah.
Every year we see 1 or 2 kids develop HUS, whose family is giving them raw milk. And so I think there's, in the general pediatric population, when you're seeing these kids, from day one, it should be stressed that children should not be given raw milk. And, just because that's how our forefathers did it doesn't mean that it's the right way to do it, because a lot of them, well, all of them are dead, I guess, all our forefathers, but a lot of children died at a very young age who were primarily from infection in past eras.
So I'm one of the pediatric endocrinologists for you that I have met. My name's Meg Oberly. But I recently saw a case of iodine deficiency hypothyroidism in a 2-year-old who mom is following a really strict elimination diet for her kid because of presumed dairy and wheat insensitivities. And then also mom just naturally doesn't like the taste of iodine in her salts. So this is the first time that I've seen iodine deficiency hypothyroidism, but I was wondering, there were a couple case reports in pediatrics within the past 2 years about similar things. I was wondering if any of these diets that you discussed today put kids more at risk of iodine deficiency than others, and if that's something that you make sure that the dietitians are looking at when they're going over their diets.
So I would defer that to the dietitians about the iodine. It's not something that they're sitting close to you. It's not something that that the studies have borne out, although I am not 100% sure that they have specifically looked for that as one of the nutritional deficiencies. Is that Amanda, Jen, Paige? Do you look for it, or is it? So, yeah. Is for, yeah.
Particularly, when I grew up in the South, the hypothyroidism goiters, that was the goiter belt until they put iodine into salt. And I gotta say, all of this fancy, sea salt and stuff like that.
Yeah.
Iodinized salt. Listen to people. I mean, this is the history of medicine.
So I think it's something to add to my list of to ask about that I hadn't really thought about before. Thanks, Meg.
So my experience has been a lot of families are curious about these different diets, and I'm just wondering, outside of seeing a registered dietitian, is there a resource that you recommend to families if they want to get more information? Here, go here, this is reliable information, and then we can come back and have a discussion, or even for providers, primary care providers to learn themselves? There really isn't. The AAP, there are some statements on there. I think a lot of kind of generalized statements. I think there is some hesitation to put a lot of the dietary information out there because you need to be able to interpret it well, and each child is different. But there are some statements on various diets on the AAP, although definitely not extensive or all-encompassing.
So for you guys, the yellow book, the AAP nutrition book, which is like the red book, just as thick.
Yeah.
but is yellow and is nutrition. It is in revision right now, and there should be a new edition coming out, I think 2019. And it covers some of these diets. Bright Futures. Bright Futures covers some of this. And the AAP publishes a large book about childhood guidance for parents that has dietary information.
I don't know if we want to.
That was a great and very provocative talk, I think, for many of us that practice general pediatrics. I think it's been made, the point's been made here, but I consider this somewhat similar to our vaccine discussion with families that are, have concerns about vaccines. So I think we have to be very clear about the risks of some of these other diets, but also empathize with what the family and the kid is going through. And we can't lose sight that they're going home after our 20-minute visit with them and dealing with this crying kid who's up all night and, whatever it is. And so they will migrate to people that will listen to them and provide these crazy diets or supplements. And so it is a balance of being empathetic, yet being really clear about what their risks are and how can we work together. So I think a resource like the Yellow Book is really important to kind of continue to work with them, and maybe you have to see them more frequently so they know you're listening to them. So I think there is a risk for us, similar to vaccines, where people will just migrate to other more dangerous treatments if we're not perceived as at least listening, but also being very clear about this kind of evidence.
Yeah, I totally agree with that, and I think a lot can be said about listening.
Brazil's food-based dietary guidelines is a fantastic PDF online. It's 100 pages. It's a ton of pictures, very colorful. And they talk a lot about eating together as families is also very important. It's for proper health. And I thought that was a pretty nice thing that I just found online recently. So, anybody else?
Brazil, you said?
Yeah, Brazil's food-based guidelines.
So to bring together a magic confluence of controversy, can you comment on perhaps the specific target of autism and families following the craziest eliminations I've ever seen are in kids who have autism, whose families are trying to ameliorate those symptoms or not vaccinate them. Thoughts about ways to particularly target that group where there's even more poignancy in the way they try to eliminate?
I think so, and it's again talking about kind of like what Dave said, is really listening to the families, trying to empathize with their concerns, talking about the risks, especially in autistic children who often are going to have already limited diets. And so when you start doing some of these more empiric eliminations, they become much more at risk. And so really kind of focusing on that, I think that's one group where definitely finding a dietitian for them to see is important because they do become higher at risk. And so it's the same kind of process as that empathy as much as you can have, although unless you have your own autistic child with limitations you aren't fully going to understand, but being there to listen and trying to work with them and come up with a plan and a strategy for maybe trying some things, but knowing that if it's not working, that you're going to change and go back to to standard diets. All right. So we're good. Thank you very much.
You have been disconnected from the meeting.